Good morning and welcome to this non-CME corporate forum sponsored by Blueprint Medicines entitled Answering the Call in Non-Advanced Systemic Mastocytosis, Targeted Approaches to Patient Management. We are honored to have participants from across the country here this morning, not only in this room, but also viewing online. A few important housekeeping notes for those of you in the room. To answer the polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. The information being presented is available online. The link is listed on the card in front of you. This card also provides links to valuable SM-related clinical resources, educational activities, and patient testimonials. As part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the evaluation form. For everyone joining us online, the system will prompt you to answer polling questions, and the information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. Now, let's give a warm welcome to this morning's presenters, Dr. Matthew Giannetti and Dr. Ann Maitland. Enjoy the program.
I know. It's a lot of years.
Good morning.
Good morning, everybody. Hello, and thank you for having us. We're here to talk about answering the call in non-advanced systemic mastocytosis. My name is Matthew Giannetti, and I'm here with Dr. Ann Maitland. So we'll go ahead and get started. Okay, good. Disclosures. So just to start out, a couple disclosures from both of us. I do receive consulting fees from Blueprint and Cogent, and I have some contracted research for Blueprint, and I'm on a medical safety board of a small company named Imaging.
And I'm also receiving honorarium for Blueprint, as well as on the advisory board for both Cogent Biosciences and Tercera, and I also on the Speakers Bureau as well.
Okay, so to start off today, a couple of key learning objectives. So we're going to describe the pathophysiologic processes in systemic mastocytosis with a focus on potential clinical manifestations and the rationale for the new targeted tyrosine kinase inhibitor therapies. We will talk about evaluation of patients with suspected non-advanced systemic mastocytosis and characterize symptoms, disease burdens, and results from testing. And then finally, we're going to review the clinical trial evidence and appropriate use of targeted therapies for non-advanced systemic mastocytosis, including individual treatment regimes for non-advanced systemic mastocytosis, reflecting clinical evidence and efficacy and safety. So to start, a couple of pre-test questions. I think everybody has clickers on their desk if you want to pick up your clickers. So pre-test question 1, approximately how many patients with non-advanced systemic mastocytosis do you treat each week? And this, just to be clear, this is not a correct or wrong answer. This is just for information. Okay, great. And we'll review these answers at the end of the seminar as well. We'll have a nice little bar graph prepared. Pre-question 2. Approximately what percentage of patients with systemic mastocytosis have a KIT D816V mutation? All right, third pretest question. A 56-year-old man experienced anaphylaxis following a wasp sting. He states he often experiences acute abdominal cramping, pruritus, and nausea. Which of the following would be the next optimal next step? Okay, and a final pretest question here. Number 4, in approximately what percentage of patients with suspected systemic mastocytosis do you currently, and please see do you currently in capitals, use high sensitivity assays to detect a KIT D816V mutation? Okay, and final 2 truths and a lie. This is the game I play with my kids at dinner every day. It's a different context, maybe. All right, patients with indolent systemic mastocytosis frequently experience cytopenias, splenomegaly, and bone marrow failure. 2, ISM is more often associated with mast cell mediator or skin symptoms than with organ dysfunction. Or 3, the risk for anaphylaxis is higher in patients with bone marrow mastocytosis than patients with ISM. And the goal here is to guess which one is actually the lie. So please click on the number that's the lie. Great. So the majority did get that correct, 68%. So cytopenia, splenomegaly, and bone marrow failure, you can absolutely see these in systemic mastocytosis, but these are generally criteria for more advanced variants of mastocytosis. So cytopenias and bone marrow failure are typically C criteria. Hepatosplenomegaly with normal function would be a B criteria. Okay. So now that we have the intro questions out of the way, let's get down to talking a little bit about mastocytosis. I will handle the first portion of the talk here, and I want to review pathophysiologic processes, particularly focusing on the non-advanced variants of systemic mastocytosis. So first, systemic mastocytosis is a rare clonal mast cell disorder. It affects approximately 1 in 10,000 people. It's actually a little bit less than that. There's not great data for this, but a paper from 2014 out of Denmark actually put it at 1 in 12,000 or so. It's classified by the World Health Organization as an orphan disease. So again, truly, this is quite a rare disease. Within the whole spectrum of systemic mastocytosis, you can see many more purple people here as opposed to yellow people. And that implies that the vast majority of patients have non-advanced systemic mastocytosis, i.e. purple, whereas the minority are going to have advanced systemic mastocytosis. So the types of non-advanced, generally we think of indolent SM as the majority, smoldering systemic mastocytosis, and then bone marrow mastocytosis. We'll talk about the specifics in a minute. And then the advanced forms of SM, we won't cover today, but just for your knowledge, SMAHN, when you have systemic mastocytosis plus an alternative, typically myeloid neoplasm, aggressive systemic mastocytosis, and then mast cell leukemia. There's no apparent gender or ethnic bias. There's a slight preponderance towards males, particularly in kids. And then the average 6 to 9 year diagnostic delay from symptom onset to diagnosis can be much more than that, truthfully, as well. So exploring KIT mutations in systemic mastocytosis, the general understanding is that everybody who has a clonal mast cell disorder has some form of a KIT mutation or activation of the KIT protein. Classically, we think of KIT D816V because this comprises about 90 to 95% of patients with mastocytosis. So I think that was pre-test question, I don't know, 2 or 3 or something like that. You can see down here, 95%. So this is a picture of the KIT protein, a cartoon of the KIT protein. And you can see that over here with stem cell factor bound, or we don't have a D816V mutation here, but either way, if you have the D816V mutation, it makes it not dependent on stem cell factor, so it provides constitutive signaling. KIT immediately activates Src kinases, and then there's a cascade that we kind of have drawn here. The specific signaling pathways for this talk are less important. What is more important is that the KIT D816V mutation provides constitutive activation to the KIT protein. And so this causes more mast cells to mature, more mast cells to proliferate, and more mast cells to leave the bone marrow and migrate into tissue. Mast cell mediators. So these are super important, and these comprise the bulk of, these are responsible for the bulk of symptoms in the non-advanced variants. So you can see here environmental stimuli. This can be allergens, this can be vancomycin, this can be Hymenoptera sting, whatever it may be, activates the mast cell and then leads to a cascade here. So when I think of mast cell activation, I generally describe it in three kind of primary ways. So the preformed granules, preformed mediators are found in the granules. These release like immediately, within seconds to a minute or two after mast cell activation. You get histamine, tryptase, heparin, and there are some cytokines in there as well. The second part is the lipid mediators. So these are derived from the cell membrane. Arachidonic acid is liberated from the cell membrane and then subsequently processed into leukotrienes, prostaglandins, et cetera. This is more in the order of like 5 to 10 minutes after mast cell activation. And then much later, the mast cells pour out chemokines and cytokines. So we have just 3 listed here. There's truly like 50 or 60 of them, so plenty of chemokines and cytokines. Okay, known triggers for mast cell activation events. This is a big list. You know, all of them can trigger mast cell activation. The things that I would like to focus on or highlight to the audience here, the top really 3, I would say, maybe 1 and 3 probably are the most important. So venom by far is the most important. Approximately 20 to 25% of patients with systemic mastocytosis can have life-threatening episodes of anaphylaxis upon sting. And so this is the reason why we prescribe people EpiPens actually for ISM, among other reasons, one of the reasons. Foods can do it, particularly in patients with a history of food allergy previously. My experience has been these can cause hives and other things like that, or flaring of the spots, but not necessarily fulminant anaphylaxis. And then drugs, the classic is going to be NSAIDs and some antibiotics, so we should always be careful of those in this patient population. And to be clear, when I say be careful, it doesn't mean do not prescribe. It just means the patient should be aware of them. If they've tolerated them previously, it's fine to continue using NSAIDs with caution. So best practices in systemic mastocytosis diagnoses. This is a mast cell. This mast cell releases lots of things, as you can see here. So the clinical consequences, I mean, this is like all organ systems in the body, essentially. So mast cells are not tissue restricted, which means they are able to go in multiple, almost all tissues throughout the body. And when they're located in a tissue and they degranulate, they can cause local tissue site effects via their mediators. So you can see in the cardiovascular setting, tachycardia, hypotension, or syncope. This is classically seen in anaphylaxis. Cutaneous is probably the most common manifestation of mast cell activation. So I typically think of patients who have cutaneous lesions, flaring of those spots, redness, itching, et cetera. And even those who don't have spots can have hives, flushing, respiratory. These tend to be a little bit less common, but we do see dyspnea, wheezing, shortness of breath. And then you can see here many of the other things. So digestive, neurologic, musculoskeletal, systemic. I would just focus the last thing here on digestive. So GI symptoms are very, very prevalent in mastocytosis. They tend to either be chronic baseline symptoms such as bloating, diarrhea, nausea, or the much more acute settings that you can have with anaphylaxis, where you have acute sudden onset abdominal cramping followed by diarrhea. Okay, systemic mastocytosis, standard of care. So you can see here there are 4 different things: laboratory, morphology, genetics, and phenotype. All of these should be done in tandem. So lab, CBC differential, tryptase, comprehensive metabolic panel. This is looking for any labs that may tip you off to a diagnosis of systemic mastocytosis. Genetics is probably the second next important test. So PCR, looking for the D816V. You know, really important here, I feel like I've said this like 5,000 times over the past couple days, but digital droplet PCR has a much better sensitivity for these, so it's really important that you're amplifying the KIT mutation before you're analyzing it. So the labs that can run this, classically Mayo and Arup. There's a couple of other labs as well, but really important that it's a digital droplet PCR. Other genetic testing, so myeloid, NGS, this really should be done on the bone marrow, and testing for HAT, alpha-tryptocemia. So up here, morphology, we have blood smear, bone marrow aspirate smear, and bone marrow biopsy. The bone marrow biopsy is going to be the standard of diagnosis, so you need a bone marrow to diagnose systemic mastocytosis, or another tissue, so for example, GI biopsy, but it needs to be a tissue diagnosis. And then finally, phenotyping cells. So once you have these cells, once you have the bone marrow or the tissue sample embedded in wax section, you can stain it for things like CD2, CD25, CD30, but also tryptase as well. This gives you a picture of what the mast cells look like and helps you meet diagnostic criteria for systemic mastocytosis. Okay, good. High sensitivity assay. So this is what I was saying earlier. So sensitivity and specificity affect detection of KIT D816V. So the really important point here, I don't know if it's talked about in the slides, but mast cells live in the bone marrow. And they live in the bone marrow, they leave the bone marrow, briefly go through peripheral blood, and then land in tissue. And so when you're looking for a mutation in peripheral blood, you're looking at this mutation classically in mast cells. The problem is that there's very few mast cells circulating in peripheral blood. So if you have just 1 or 2 mast cells that you pick up in a blood draw, you really need to amplify that mutation so you can reach the level of detection. So in particular, when doing this assay in peripheral blood, it really needs to be a digital droplet PCR assay. When you're doing it in the bone marrow, you can often pick up the mutation via next generation sequencing. But even in the bone marrow, good practice is to be doing a PCR-based assay. And then you can see here, KIT D816V mutations were detected in 95% of peripheral blood samples versus only 28% by next-generation sequencing and 80% by the local detection. This is usually just a lower sensitivity PCR test, so it's certainly better than next-generation, but not quite as good as the digital droplet PCR. And for the digital droplet PCR, I think maybe just so people have an understanding of what is regular PCR versus digital droplet PCR, if you're looking for the KIT mutation, you have a particular primer or a sequence that is at the front or the back of it, and you say amplify this sequence, and you use a PCR hot-cold cycle and it amplifies it. Digital droplet, it essentially, you pour some oil in there, and the cells get suspended in a small little oil droplet. So you have maybe 1, 2, 3, 4 cells per oil droplet, and you PCR each individual oil droplet. So you're really looking at down to 4 or 3 cells. So the sensitivity with these techniques is much better. It's also much more labor intensive and really requires a specialized lab, which is why we're usually sending these out to the reference labs such as Mayo or Arup. Okay. Decision to perform bone marrow biopsy in adult with suspected SM. So this is a lot here. Do they have skin lesions? If the answer is yes, basically you bone marrow them. Generally, I like the tryptase to be a little bit above 20 to 25 before I bone marrow in this case. If they have a couple of spots and they're asymptomatic and their tryptase is 8 or 9, the bone marrows can often be subdiagnostic because it's very heterogeneous. So it's not wrong to perform a bone marrow, but if they don't have it or they don't meet criteria for systemic, it may simply be a subdiagnostic marrow. On the right-hand side, if they don't have skin lesions, then you ask these other questions: pre-syncope, syncope, mediator-related symptoms, anaphylaxis, unexplained osteoporosis. Particularly anaphylaxis with hypotensive syncope, that warrants a bone marrow biopsy in my book. So does unexplained osteoporosis with an elevated tryptase. These things are very specific for mastocytosis. So you can see yes, is tryptase greater than 20, then yes, you bone marrow. If no, you can look for the KIT mutation in peripheral blood. And this is just a rough guideline. There's also a really nice score that I believe this was based on called the REMA score. So the folks in Salamanca, Escribano's group historically provide this REMA score where you input a bunch of information: age, sex, anaphylaxis, etc., and it gives you a nice score in which guides the decision making for bone marrow or not bone marrow. All right, differential diagnosis. So there's a lot of other things that we need to consider. This is actually one of the major challenges with systemic mastocytosis. So you can see here, alpha tryptosemia is caused by extra allelic copies of alpha tryptase. By definition, these patients have an elevated tryptase, so that can be confusing. That's actually by far the most common reason for an elevated tryptase in the general population. Monoclonal mast cell activation syndrome, this is a clonal mast cell disorder. We, or at least maybe me, think of this as indolent systemic mastocytosis, essentially. With enough bone marrows, you will usually meet diagnostic criteria. And I'm not saying that you should send your patients for bone marrows, but I would think of this as an indolent systemic-like condition. Other conditions to consider, these are all things that can mimic symptoms in mastocytosis or mimic anaphylaxis. So cardiovascular, right? If somebody's having pre-syncope and passing out, you need to be concerned about arrhythmias, orthostatic hypotension, et cetera. And then a handful of other conditions. I'm not going to, I'm not going to read all these, but digestive, endocrine, immunologic, neurologic, skin, et cetera. So WHO diagnostic criteria for systemic mastocytosis. There is 1 major and 4 minor criteria. You can meet criteria by having 1 major and 1 minor, or by having 3 minor. So the first here, major criteria, multifocal infiltrates of mast cells. I think this is a tryptase stain on H&E. It's kind of hard to say, but if you look at a slide with mast cells, there's very atypical appearance where the mast cells are directly touching each other, and in particular, more than 15 cells are touching each other. So that's the major criteria, and that's a tissue-driven criteria, so you need a tissue biopsy of some sort. Minor criteria, serum tryptase level greater than 20, KIT D816V mutation, 25% or more of mast cells are spindled. And you see this really atypical spindle. You can't see the nuclei here, but the spindling refers to the nuclei. It has this very unique, almost cigar-shaped appearance, and it's very atypical for mast cells. And then finally, the last criteria, CD2, CD25, or CD30 detected on the mast cells. You can do this either in the bone marrow aspirate via flow cytometry, or you can actually stain via immunohistochemistry on the marrow core sample. So pitfalls, basal serum tryptase variability and alpha tryptosemia can affect whether minor criteria is met. So serum tryptase can vary considerably among patients with mastocytosis in an individual, and even more so actually in alpha tryptosemia. And so anybody with a tryptase of greater than 20, that's a minor criteria, so this can affect variability. Cases with serum tryptase greater than 8 when other minor criteria are present, so MCCD25 and spindling. We actually published on this in the bone marrow not so long ago. Alpha tryptosemia essentially can mimic this. So you don't get the full aggregates, but you'll get 2, sometimes 3 mast cells touching each other. So that's definitely abnormal. You don't reach 15, so it's not the major criteria. The significance of that, I don't think at present is well understood, but it is definitely abnormal. And then centralized expert bone marrow sample evaluation suggested. This just means pathology is really important here. So many pathologists have not really diagnosed systemic mastocytosis or have done it only on a handful of episodes. And so sending it to somebody who really knows what they're doing is helpful. I'm spoiled in this regard. Jason Hornick at the Brigham is phenomenal, and I go down there regularly, maybe once a month to view with him. I realize not everybody has that, but there are local academic centers which you can tap into to have a second pathology opinion if there's some diagnostic uncertainty regarding the samples. And then important to remember, some systemic mastocytosis cases can have peripheral blood KIT D816V negative. I would say some truly are bone marrow KIT D816V negative as well. And if they are negative and less than 5 mast cells in the bone marrow biopsy, it's hard to get criteria, especially if they don't have aggregates. And then monoclonal MCAS has some pathophysiologic characteristics that overlap with SM, including the presence of KIT D816V and CD25 on mast cells. And by definition, monoclonal mast cell activation does not meet criteria for SM. Okay, call a colleague. So I think we're going to call Matt Hamilton here, who is a colleague but also a good friend, to talk about GI presentations.
Hi, Matt. Thanks for calling.
Excellent.
Hi, Matt. Thanks for calling. You know I'm always happy to share my perspective as a GI and share that perspective with our allergy and immunology colleagues. So you want to talk about GI manifestations in patients with non-advanced systemic mastocytosis. Happy to help with that. What are those symptoms? Most commonly, it's diarrhea, loose stools, precipitated by abdominal pain, cramping, things like that. When a patient is triggered by something. These are typically intermittent symptoms. Occasionally, patients will also have other GI symptoms as well. So this is nausea, abdominal bloat, reflux. These are common symptoms. There may be overlap with other GI conditions, these GI symptoms. There may be overlap with IBS. Other inflammatory conditions will present in a similar way. A lot of these patients will have underlying peptic ulcer disease, as you know, patients with mastocytosis. So it may be helpful to have a GI involved to help sort of tease out what's driving symptoms. Is it due to the mastocytosis itself, or is it due to another GI condition potentially? When do you get endoscopy and colonoscopy in these patients? You know, I think before we get into what we're going to be looking for, I mean, why we might be doing this, I think if we don't yet have a diagnosis of non-advanced SM, GI biopsies through endoscopy and colonoscopy can be helpful to establish a diagnosis. When a patient, maybe you can't get a bone marrow biopsy for some reason, you can get the GI biopsies, and that may be diagnostic of SM. So in another scenario, it's possible even patients that have diagnosed SM, sometimes we do endoscopy and colonoscopy and biopsies because we're trying to tease out other conditions, especially those patients that have persistent symptoms. So just so you know, I mean, when we're doing the endoscopy and colonoscopy, what are we looking for? Most of the time, things look pretty normal inside. There may be little subtle abnormalities here and there. The key is the endoscopist needs to take random biopsies, and typically these are segmental biopsies throughout the GI tract. So you make sure you tell your GI endoscopist this, to take multiple biopsies in all the segments, and most gastroenterologists know what that means. We do this in other conditions as well. Mastocytosis can be throughout the gut. Most commonly, it's actually in the lower GI tract, colon, terminal ileum, but also in the upper GI tract. Colonoscopy is probably the highest yield test, but typically we do colonoscopy and endoscopy in these patients with non-advanced SM and GI symptoms. It's important that we tell the pathologist what we're looking for when we do the biopsies. So we do our standard stains, but then we have to do special stains to highlight the mast cells. So we're doing CD117 stains, which is the most specific stain we have to highlight the mast cell. This is actually even better than tryptase. And then in a non-advanced SM, to look for SM, we're doing the CD25 stain as well. The key finding that the pathologists are going to be looking for are those aggregates of mast cells in the gut mucosa. So remember, 15 or more mast cells, the aggregates of mast cells, that's going to be diagnostic of mastocytosis. You know, this is different than the scenario that we see in patients like healthy controls, for instance, when we do biopsies and look for mast cells. We see more scattered mast cells throughout the mucosa. We're not seeing aggregates. It's also different from other conditions like inflammatory conditions, inflammatory bowel disease, where we're seeing potentially increased numbers of mast cells, but they're still scattered about, they're not aggregated. So in SM, we're looking for those aggregates of mast cells. So, I really hope this helps, Matt. Again, I always like to talk to you about GI manifestations and non-advanced SM. I hope this was helpful to your colleagues, and I hope we get a chance to catch up again and work together soon.
So thanks, Matt. He actually has clinic on Tuesday, like 2 floors below me. He's part of our Mastocytosis Center at Brigham, so I often walk down there and pester him, so he needs to be careful of his word choice. The other thing I would mention that's really important that wasn't mentioned there that I get a lot of consults about is counting mast cells in the gut. So do not count mast cells in the gut. So he actually didn't report here, but he published a paper with Jason Hornick a little while back, maybe 2016, 2015. Many people, regardless of their condition, whether you have mastocytosis, whether you have mast cell activation syndrome, whether you have irritable bowel syndrome, or whether you're a healthy control, have widely variable counts of mast cells in the gut. So we've seen up to 80 in totally healthy people. The key finding is aggregates, right? So if you have lots of mast cells, that is not diagnostic of anything. If you have lots of mast cells that are all touching each other, that is very abnormal, and that is diagnostic of systemic mastocytosis. But please remember, don't ask your pathologist to count the mast cells. It is very labor intensive, and it is not diagnostically helpful. Okay, moving forward here, classifying subtypes. So these are all variants, actually. So bone marrow mastocytosis is really defined by it being in the bone marrow. These patients classically have anaphylaxis, low serum tryptase, and often anaphylaxis to Hymenoptera. ISM is no additional B or C findings. Smoldering is where you have a very high burden of mast cells, classically tryptase over 200 and more than 30% in the bone marrow. This is a condition that's much higher risk to progress to a more advanced variant. And then ASM is where you have fulminant organ failure or organ dysfunction. So cytopenias with bone marrow failure, hepatosplenomegaly with portal tension, hypersplenism, all of these things when the organs stop working, this is indicative of a more advanced variant. Okay, so quality of life tools, these are all quite helpful. I would say at present, most of these are in the research domain. I don't regularly do these for patients, but I can see it in a clinic in which you're really trying to gauge improvement. These quality of life questionnaires are great. The one we use for most of our clinical trials is a function of the ISM SAF here at the bottom, but all of these, I think all 3 of these have been validated actually, although don't quote me on that, please. Potential predictors of poor prognosis in SM. So there's a couple of things. So disease subtype, obviously, basal serum tryptase level, so I get concerned when I see tryptase greater than 200 at the time of diagnosis. A really high variant allele fraction, so you need to have it sent to an appropriate lab to even diagnose that. Age greater than 60, and then elevated ALK phos. Generally, we think of the risk of progression as such. So bone marrow mastocytosis is very low, ISM is low, SSM is intermediate. These have a lot of overlap, though. So, I have had bone marrow mastocytosis patients who can progress, ISM can progress, and I think we don't have a lot of great data, actually, to give specific numbers. So for ISM, I typically quote people at about 5 to 10% lifetime risk of progression to a more advanced variant. Okay, with all of that being said, I will now hand the mic over to Dr. Ann Maitland.
We're up there with the U.S. truck on the 4x4. Good morning, and I'm delighted to be participating in this. And we're going to talk about how we can help these patients who have a large burden of disease, impaired quality of life. I would say literally 50% of them end up cutting back their participation at work or school. Over a quarter of them end up not going on to disability. And because of their risk of having hypersensitivity reactions, you can imagine that they start, basically have a very closed social experiences. They just end up having a very small world because they don't want to get sick. So when it comes to individuals that are diagnosed with non-advanced forms of systemic mastocytosis, we're really talking about not necessarily disruption of the organ architecture. We're really talking about release of chemicals. And I want to emphasize here that mast cells are not one-trick ponies. They have plenty of different receptors that will cause different release of chemical mediators. So a lot of the mediators that can be released, we have medications available. And on average, a lot of these patients are taking at least 3 to 4 medications and still are quite symptomatic. So the first thing, histamine is a big player. You have the availability of first and second receptor antagonism, which helps in suppressing some of the symptoms that are associated with anaphylaxis, and can also be used for prevention if someone's undergoing a procedure, anything from a dental procedure to radiology. Especially since that MERG receptor might be sensitive to some of the contrast agents, you might want to have a pre-medication protocol and possibly a pre-hydration protocol to prevent them from having a reaction. The other mediators to think about, especially a lot of these patients may present with gastroesophageal reflux disease. You have the proton pump inhibitors as well as H2 blockade. You have mast cell stabilizers, including cromolyn. And just to let you know, cromolyn is available not just in a GI preparation. We have a respiratory preparation, both upper and lower. There's the magic masto cream where you can take a vial and throw it into some hypoallergenic emollient and that they can use to help suppress itch, flushing, or urticarial reactions. There's also the advantage of ketotifen. For instance, most of you might be familiar with ketotifen as an eye drop, including Zaditor. But it's also available primarily through compounding pharmacies, or if you want to talk to one of your Canadian pharmacies, they can also provide it as well. You have leukotriene antagonism, and then you have at the level of the receptor, including montelukast and zafralukast. Actually, zafralukast is the bigger brother. I find it to be a little bit more effective, but it's important to monitor liver function. So I usually will get liver function tests, and then after a month, I'll recheck it again. If there's any issues with the liver function test, we just stop the medication and the liver usually goes back to its normal functioning level. And we also have the advantage of a 5-lipoxygenase inhibitor, xyluton, a little bit more harder to obtain for prior authorization, excuse me, but very effective as well. So is corticosteroids. We try to minimize that use because these individuals are already at risk for having bone marrow osteopenia, osteoporosis, so you want to be careful about its use, but definitely helpful, especially if there's anaphylaxis, chronic urticaria. Be mindful of it. We also have the advantage of a biologic that's been around for quite some time for chronic urticaria as well as asthma with an allergic component, and that's omalizumab. And then if you're having individuals that are having bone pain, for instance, you have the availability of bisphosphonates, you have interferon alpha and decenobab, and vitamin D supplementation. So you're really going to try to identify, remembering that mast cells can be in any part of the body. It's really important to have a surveillance of all the different symptoms and then use medications that target those individual symptoms. And I usually tell the patients, look, it's really important that you come back after 4 weeks, let me know if you're tolerating the medication, if you're having any adverse events to the medications. And actually I did not mention the fact that I also use tricyclic agents because they have the ability to go after the H1, H2, and H3. So it's very helpful for patients that are having bad pruritus that may be disturbing their sleep. I usually do that at night and then use a first generation or second generation H1 blocker in the morning. So for individuals that have, you're definitely going to assess for the possibility of having or had a history of anaphylaxis. It's important to start them on venom immunotherapy. And once it's started, they need to stay on it. This is a chronic condition that's not going to get any better, but this will at least reduce, if they get stung again, it'll reduce the chances of having a really severe outcome from that sting. I already talked about omalizumab. It's been shown to be effective in both clonal and non-clonal mast cell disease. It's been around since 2003, so we kind of know the good, the bad, the ugly of this medication. It needs to be administered. I have a tendency, and I don't know about you, Matt, but I have a tendency to start them on a lower dose to make sure that they tolerate it, and then work them up to a dose that's appropriate for which I got the prior authorization, whether it is for chronic spontaneous urticaria or for asthma. Every patient gets epinephrine in some way, shape, or form. And then we have the use of avapritinib, which is a selective protein tyrosine kinase inhibitor, and we'll get a little bit more into the details about this protein tyrosine kinase inhibitor that targets the mutation that impacts 95% of the patients that have indolent systemic mastocytosis. So, as I said, mast cells are not a one-trick pony. Their job are to be first responders at any part of the body that's exposed to the environment. So they have lots of different molecules to sense not only danger, such as the alarmins, but also direct and indirect markers to detect what kind of danger it is. So you have the complement receptors that recognize C3A and C5A, which originally were called anaphylatoxins. You have the c-KIT receptor. You have immunoglobulin receptors, including IgG and IgE. And depending on the receptors that are engaged, you'll have different programs that are released. So sometimes you'll have degranulation programs. Actually, another receptor that's really important to have on here is the MERG receptor. That's that G protein coupled receptor that Mariana Castells elucidated on its role in perioperative anaphylaxis and peri-procedure anaphylaxis. So this is what is vancomycin-induced red man syndrome. And so depending on what receptors are released, you'll have different degranulation programs. Some will cause instant degranulation, others will have delayed. And you also have secretion of de novo produced cytokines and chemokines. So there's where you have that downstream effect minutes to hours later as well. The avapritinib targets that D816V that leads to constitutive activation of one of the major receptors in mast cells. And what's important to know is that this is a medication, and that I hope to show you with the next slides. One day, one dose, 25 milligrams, once a day. And be careful about making sure they're not washing it down with grapefruit juice or using other medications that go through the CYP3A pathways, has the ability to reduce these symptoms and improve the quality of life of these patients that have been enduring it for anywhere from 6 to 9 years before they received a more suitable working diagnosis. So avapritinib was looked at in the Pioneer trial, and as Matt had mentioned, this is a rare disease, but this was powered with over 200 patients, which is actually pretty good. And what I found to be very fascinating in this study is that although we look for systemic mastocytosis in 20 or above, there were patients as low as 3.6. So if you have a suspicion that somebody has a clonal mast cell disorder, you really need to look at it in lots of different ways before you say they don't have it. But here they actually looked at three sets of organ systems and constitutional symptoms, anywhere from bone pain and fatigue to GI distress, as Dr. Hamilton alluded to regarding GI distress, abdominal pain, reflux, nausea, skin symptoms including the increase in burning of spots, itching, flushing. Then you also have neuropsychiatric manifestations including dizziness and fatigue and headache. So you can see that depending on where these mast cells are releasing these chemicals, you'll have multi-organ system involvement. And in the individuals that were enrolled in this trial, basically they were getting the best supportive care plus or minus avapritinib. And what they showed within, by the end of the 24-week trial, you had a significant reduction of these symptoms that were captured with daily symptom scores, of a reduction. On average, these individuals reported at least 50 points. So there's 10 points for each one of these symptoms, and they went down 15, as opposed to the placebo, which was 9. And that's actually pretty impressive, especially if you've been suffering for so long. Remember, these patients are not going to work, they're not hanging out with their families and friends, and they're actually going on to disability. So you actually would be able to give people back their life by using medication like this. And then also, what I really loved about this study is the primary endpoint were symptom scores, but now let's see if we can back it up with objective data. And what we're looking here is, compared to the placebo, you had significant reduction of serum tryptase. Over 54% achieved a 50% reduction or more in the serum tryptase. Not as robust with the bone marrow mast cell aggregates, but significant enough. And understand, in these patients, sometimes it's just not the c-KIT mutation that's causing issues regarding the ability for these mast cells to be more constitutively active. You saw a significant reduction in the D816 variant as well. And then that correlated again with significant reduction of the symptom scores. So here you have data showing that a single tablet with a pretty good safety profile, and we'll get into that, has the ability to reduce scores and also reduce objective data. And it would be interesting to see the outcome, the follow-up regarding the studies and what happens with these patients using avapritinib and the risk factor, as was previously alluded to, that maybe this has the possibility of reducing susceptibility to advancement to more severe forms of disease. So when it comes to treatment considerations for individuals that are asymptomatic, so you might have somebody who just has fatigue, for instance. It's important that if they are pretty well controlled, you want to have them, especially for the indolent forms, you want to make sure you have a thorough H&P, so you're assessing whether or not they have any symptoms, again, impacting any organ system. You want to make sure that that CMP, and especially the alkaline phosphatase, is normal, liver function is normal, there's no evidence of adenopathy anywhere. You want to make sure that the bone structure is intact with a DEXA scan. We look at a total serum Ig, but just to let you know, you can actually have antigen-specific IgE even with a quote-unquote normal Ig level, and especially look for the possibility of allergen-specific IgE to stinging insects. Every patient that leaves my office has action plans. They have action plans if they have anaphylaxis. They're actually written orders because a lot of emergency departments don't like asking for tryptase. And so, and I actually shared in previous lectures, I actually do a little MacGyver maneuver, and when the emergency departments don't want to check a tryptase, I just ask them to get a BMP, and then I'll fax an order into the lab to add tryptase on. Also, the preventative plans, so H1 blockade, leukotriene antagonism, possibly corticosteroids for certain procedures or surgery. And then it's really important to just make sure that everything that you've recommended when you have them come back for their annual visits or semi-annual visits, that their symptom burden is under better control. Now for individuals that are much more symptomatic, you already started, and as I said, these patients are on 3 to 4 medications. They're taking histamine blockers, they're taking ketotifen, they're taking cromolyn. massage, it's important that you counsel the patient on being mindful, because a lot of people end up acclimating down to what their bodies are letting them do. And so having them fill out a symptom questionnaire, as was previously mentioned, Matt, that we keep this, you're able to document what they're seeing and doing regarding whether or not there's any evidence of progression, increased chemical mediator release that's causing anything from neuropsychiatric issues, brain fog, to gastrointestinal distress. I find it very interesting that, and again, this is a team sport. It's really important for other practitioners to be involved. The first patient series, was actually a joint effort at Brigham and Women's between allergy, immunology, and gastroenterology. And what was concerning there is those patients were parked in an IBS clinic for 5 to 7 years with medications that were ineffective. So it's really important to involve your colleagues in trying to understand that it's not just the skin, it's not just the GI tract, and who knows, how many of your patients come through complaining of fatigue? So this is something that should be considered on the diagnostic. And then after you've tried targeted mediators, now it's time to consider the use of a medication like avapritinib to see whether or not it gets the symptoms under control. So considerations for the use of targeted protein tyrosine kinase inhibitors. So this class of medications have a tendency to be associated with bleeding risks, especially possibly intracranial hypertension, intracranial bleed. And so you want to be careful about administering this medication to someone who has a platelet count of 50,000 or less. I've not had most of the patients that I had, there's no evidence of thrombocytopenia, but I'm sure you probably have a little bit more experience with this. It's definitely a joint effort between hematology, oncology, and allergy immunology to try to get this under control as well. And you definitely want to monitor for this. If somebody has a change in cognition, start nausea, diarrhea, pain, it's important to evaluate for the possibility of having a bleeding issue. Subset of these patients will have a faster progression, so here is where maybe intervening with avapritinib may stop that progression and get their symptoms under control as well. And then it's important to know that this is only available through specialty pharmacies, especially, and you have resources from your representatives who can tell you what pharmacies will be available to your area. So when it comes to investigational agents that have been used in the past or are currently in trials, you're again looking at the various receptors that have the ability to cause chemical mediator release. So you have medications that are targeting the c-KIT receptor, including mastinib, elenistanib, bezuclastinib, midostaurin, and then you also have targeting the interleukin-6 chemical mediator release with saraluminib. And then hydroxychloroquine. And so you can see from the chart on the right, many of these studies are in phase 2 or phase 3. And so to be seen, but we actually have one paper that was done in Journal of Allergy and Clinical Immunology in 2018, which was an open label use of midostaurin, and midostaurin was actually shown to reduce symptom scores at least 20 to 25%. So now we're going to go into a patient-centered management of a chronic clonal mast cell disease in the form of non-advanced systemic mastocytosis. So here, suboptimal identification and delayed burden of diagnosis is quite common in individuals that have this clonal mast cell disease. You can see that it takes 4 years for someone who has the diagnosis of a bone marrow mastocytosis. Indolent, the studies are anywhere between 6 to 9 years. And interestingly enough, individuals that actually have B findings, it takes even longer for these individuals, especially if it's a question of fatigue contributing to this. That's smoldering systemic mastocytosis. And you can imagine that these patients are going to different doctors, especially if it's spots that are bothering them, they might be going to dermatology. If their gastrointestinal tract is bothering them, they're going to GI. And then if you're tired, it's primary care for the most part. So we really need to kind of get the word out there, even to our primary care colleagues that this is something that needs to be should be on their differential diagnosis and allow us to try to intervene. And especially if somebody has venom anaphylaxis, this is again a comment that we need to work with our emergency medicine personnel so that they learn to refer out as opposed to just giving an EpiPen and wishing them well. So we're going to call another colleague because again, a lot of these individuals that have cutaneous mastocytomas will present to a dermatology practice. And our derm colleagues have a tendency to just focus on the skin. And as I said, this is a multi-organ system involvement. So we're going to listen to one of our colleagues who is a dermatologist who's quite familiar with systemic mastocytosis and has the ability to give us some insights. Morning.
Hello, and thank you for calling. I think this is an important topic, and I'd be happy to share my perspective as a dermatologist. I have the unique pleasure of serving on a multidisciplinary team that takes care of patients with systemic mastocytosis, and I really view my role in a couple of ways. I think first, in terms of diagnosis, we can provide a lot of benefit to patients. Assessing skin lesions in patients who have mediator symptoms or perhaps an elevated tryptase. I think when patients present as diffuse red-brown macules and papules, the skin lesions are relatively specific and really highly suggestive of the disease. But mastocytosis in the adult population can also present very atypically or actually very subtly, necessitating a pretty high index of suspicion or somebody with expertise in evaluating those skin lesions. I think the other sort of side to diagnosis is the skin biopsy and actually identifying those cells in the tissue. Again, when a patient has diffuse maculopapular CM, I think most people can identify the correct place to biopsy and get a representative sample, but in those subtle or atypical cases, it can be very important. I've definitely had patients sent to me who had biopsies read out as lentigo or post-inflammatory pigmentary change who are actually inappropriately reassured that they didn't have mastocytosis. And I think that's probably an issue of where the site was initially taken and how that clinical pathologic correlation was performed. I've also had patients who have been sent to me as lichenoid dermatitis, and I think that more errs on the side of the person interpreting the pathology. So here at the center, we do have dermatopathologists who are also actually experts at identifying mastocytosis underneath the microscope. And so I think we're able to provide really high level and quality clinical pathologic correlation for the rest of our team. With regards to treatment, as you all know, this disease is very heterogeneous. So sometimes you have patients who have cutaneous limited disease or really cutaneous predominant. We've also had some patients who have been on targeted therapy who improve in all other ways but have cutaneous persistent symptoms. So for all of those patients, in collaboration with allergy and hematology, we can provide skin-directed therapies, actually better assess and address what the patient's biggest complaint is symptomatically. And then finally, we have lots of patients either through trial or now FDA approval who are on targeted therapies, and we can help to address some of their skin toxicities. So for instance, I do lymphedema wraps and ulcer management for patients who are on tyrosine kinase inhibitors, and we help out in lots of other ways. I think in a multidisciplinary team, again, I'm very fortunate to serve on one, and I think we provide really high level care to our patients because these patients are going to present, no systemic mastocytosis patient is alike. So they're going to have different needs, and having identified specialists in each department that can really address those needs, whether it be from the bone, the GI, the skin, psychiatry, to be able to really meet that patient where they're at and create a tailored plan is really valuable, and I think our patients really benefit. So it was great talking with you, and I hope you all found this information very helpful.
Thanks, Dr. Madigan. So let's talk about medication considerations in individuals that have systemic mastocytosis. So again, there's certain medications, and this is going to be provided in information sheet from the Mast Cell Disease Society. There's certain medications that definitely need to be avoided or used with caution, especially when it comes to pain medications, antibiotics, as well as anesthesia. Especially since that MERG receptor just loves soaking up the more larger molecules and causing perioperative anaphylactic events. And also when it comes to local anesthetics, there might be some individuals that tolerate lidocaine and bupivacaine more than they tolerate benzocaine or procaine. And so this is just a list that's readily available. You can download it from Mast Cell Disease Society. We actually have a 3-page action plan for patients that have systemic mastocytosis. This is what you do. If you have anaphylaxis, this is what we can do to prevent you from having a severe outcome when you take a medication, receive a vaccine, or undergo a procedure. And then especially for individuals that have pain involvement, you have to understand, although aspirin can sometimes be used in these patients, you want to make sure that they're not at risk for having anaphylaxis to the medication. So we will desensitize them as allergy immunology specialists. This is the training that we have received. Oops. So when it comes to these patients, if you have the diagnosis of indolent systemic mastocytosis, after you secure that diagnosis, I usually have them come in for the first year every 6 months. And then if I feel that they're relatively stable with the regimen, and then also checking their serum tryptase, complete blood cell count with differential, complete metabolic panel, against definitely working, making sure that the liver function, kidney function, alkaline phosphatase are within normal parameters, that they're not losing weight. Understand that is a worrisome advanced finding to find. You want to make sure that the spots are not getting any worse, and that they are actually having an improved quality of life based on whatever therapies that you're recommending. And again, because mast cells can talk with the cells that are responsible for maintaining the integrity of our bones, it's important to have a DEXA scan to make sure that they're not progressing with osteopenia, osteoporosis. Again, it's important to avoid major triggers. Sometimes going outdoors to the park, it's nothing to avoid, but you're at least prepared, and then hopefully this individual's on venom immunotherapy. Again, a plan for if they're undergoing a procedure, medications that are well tolerated to prevent anaphylaxis. Anaphylaxis action plan, please lie the patients down and then administer epinephrine. We don't want somebody having empty heart syndrome. Everyone should be having a medical alert tag, so that when I was in medical school, we actually found somebody down on the street, and it turns out she had used her EpiPen, was still non-responsive, but we were able to identify what the situation was very quickly and to attend to her. And then it's important, some of these patients feel that they're alone in the world, and there are plenty of support groups, especially through the Mast Cell Disease Society, so they feel that they can, as Dr. Baddick had mentioned, no systemic mastocytosis patient is the same. They can find someone who they can, their histories resonate and can support each other on the next leg of their journey with hopefully less symptoms. Anaphylaxis management, again, is critical. We've already talked about this, especially the importance of having venom immunotherapy if they have a history of anaphylaxis to stinging insects. Please note that individuals that have bone marrow mastocytosis are the ones at highest at risk, but it's almost pathognomonic. If you have somebody in their 50s or 60s that have a stinging insect and they're IG negative, you need to look for systemic mastocytosis as well. But the risk for anaphylaxis is high. And these are the resources that are readily available at the National Comprehensive Cancer Network, the Mast Cell Disease Society, GARD, as well as NORD. So in summary, individuals that have non-advanced systemic mastocytosis have a complex pathophysiology and clinical presentation. It's important that to know that they have a high symptom burden, which impacts their quality of life. Traditional management is helpful for some, but many actually are taking plenty of medications for years and still not showing improvement. Avapritinib is the first medication that's available for us in our toolbox to help these individuals. If you find that the more traditional interventions are not allowing these individuals to return to work, be able to participate in life, and able to not be so fearful to kind of go out into the world. This is a team sport. Allergy immunology, primary care, pathology, gastroenterology. So just to let you know, one of my patients had no bone marrow involvement, but she had 95 mast cells per high power field, like completely replacing the lining, and that would lead to her diagnosis. And so we're back to the questions at first, and hopefully some of the information that you heard between Matt and I were very helpful. So for post-test question number 1, please return to the use of your clickers, and let's see if we can shift some of those incorrect answers to correct. So we have approximately what percentage of patients with SM have a KIT DH16V mutation, Is number one 25%, 50%, 75%, or 95%? Like that. All right, excellent. Fabulosa. It's definitely 95%. And so I'd like to see the shift. So, which means avapritinib is a very logical next step for individuals that are not responding to traditional therapy.
Means they listen to you too. Look at that.
Oh, you see, you leaving me hanging. Post-test question number 2. A 56-year-old gentleman experiences anaphylaxis following a wasp sting. He states he often experiences acute abdominal cramping, pruritus, and frequent nausea. And that's a little bit frightening. So here he was identified with anaphylaxis, but he was having anaphylactic events outside of having that wasp sting. So this is something to, again, try to assess. Which of the following would be the next optimal step? Number 1, perform a bone marrow biopsy. Number 2, measure serum tryptase level. Number 3, go to the high sensitivity PCR analysis from Mayo, LabCorp for most of you, just in case you don't have access to those other two, or perform a skin biopsy. All right. So your insurance companies refer the serum tryptase first, just in case. so 82% exactly, and fantastic. And so the next question: in approximately what percentage of patients you suspect SM will you now use high sensitivity assays to detect a KIT D816V mutation? So none. 25%, 50%, 75%, 100%, or you haven't had the opportunity of managing one of these patients. Excellent. We're hoping, I would have to say, you'd be surprised, these patients are probably in your practice, and hopefully maybe this, you've heard enough to say, okay, maybe this is something that needs to be evaluated in one of your patients. And then we are at the point of, if we have questions, we already have 2. So
I'll go ahead and take some questions. It looks like, I'm throwing things at you. Got that. I think there's one for me here and one for Anne, so I'll answer the one for me first. Why do KIT mutations not manifest generally in all mast cells or in any cell for that matter? I believe you, but I'm curious. Well, I'm glad that you believe me, but don't believe me. Data is what we want, right? Data and objective facts, not my opinion. So KIT D816V classically is a somatic mutation as opposed to a germline mutation. So for example, germline mutations, I know this is a group of immunologists and not geneticists, but germline mutations will be present in every cell. So a somatic mutation is something that you acquire at some point during life. So the KIT mutation is generally acquired. It's heterogeneous in patient populations. So for example, there have been a couple of nice papers by Escribano's group where they've taken bone marrow aspirates, flow cytometrically sorted like eosinophils, neutrophils, basophils, mast cells, etc. And in some patients, classically the more advanced variants, you can find it in other non-mast cell lineages. This is a really strong predictor of progression to advanced mastocytosis. In most patients with indolent systemic mastocytosis, it is largely limited to the mast cell compartment. And it's not in all mast cells because a mutation is a singular event, right? If you have, say, 100 mast cells in your body, you probably have more than that. But of those 100 mast cells, one has a mutation. All progeny from the mutated mast cells will go on to produce KIT D816V, but you have many other mast cells that do not have the mutation. And maybe more than mast cells, stem cells, myeloid stem cells, what we should be talking about. So yes, I hope that answered your question. This one here, I think, is for Dr. Maitland.
You have to pardon me, I'm getting old, so I got to take my glasses off. How do you approach patients with vague symptoms, not anaphylaxis, who request testing for mast cell activation? So I actually published a paper about 2 years ago. It was a retrospective analysis, and once people feel that you're willing to listen and have the potential helping them, and I don't even Google my name anymore because it comes straight up. We did a retrospective analysis of 980 patients who came to my practice complaining about mast cell. And so they have an 18-page questionnaire. And out of those, there was a good number of individuals that had mast cell activation disease, but didn't necessarily meet the criteria for mast cell activation syndrome, which really focuses on a particular set of events when it comes. There's lots of different forms of mast cell activation. There's some that don't even involve tryptase and histamine. And so that means that we are woefully unprepared with validated tools to identify these individuals that have mast cell activation, or who may have mast cell activation disease. And I'm going to use that umbrella term because we don't really know what a normal tryptase is. Histamine can be released by cells other than mast cells. It can be released by basophils. Under certain circumstances, it can be released by neutrophils. And plasma histamine, by doing venipuncture, you might actually cause release of histamine as well. Heparin is not helpful because it's very difficult to measure, and thank God you don't want that out there unless you really need it. And so a lot of the times, most of these individuals get diagnosed with mast cell activation disease because they have ongoing rhinitis or they have ongoing isolated itch, and so the skin is the only thing involved. So I try to reassure them that I believe you, this is what you're happening, but I have to tell you, I've identified a lot of other things in these patients. And because mast cells are first responders, I really treat that like, and I tell the patients, you know, that having that itch or that nasal congestion is kind of like that red light that comes onto your car. Something's wrong, you got to look under the hood. And I have found immunodeficiency, I have found chronic infections, I have found autonomic dysfunction, and people I have one person who was chronically taking NSAIDs, and it was the NSAIDs that was causing the issue. So I think it's important to understand and say, look, I'm going to look. I hope I don't find anything, but if I do, I'm going to give you treatments for that. And for the individuals that have mast cell activation disease, especially a clonal mast cell disease, we have really good, more robust data testing that's available to help with these individuals. And whoever asks this question, I'm happy to kind of give you my questionnaire, because this kind of allows me to sort out what might else be going on with these individuals. And I can tell you, like a lot of individuals, like either with long COVID, they have fatigue symptoms. Mast cells are going to be involved because that's their job. They're supposed to respond to danger. And so once you get once you're able to narrow down to some better working diagnoses and give them a working vocabulary to get their symptoms under control, they do much better. And by the way, nerves talk to mast cells all the time. There's some very robust data coming out of Caroline Sokol's lab out of Mass General, as well as Brian Kim. For instance, anti-CGRP that's used for migraines, that interrupts the communication between the nerves and the mast cells contributing to the migraines. So I think it's important to understand that mast cells, it's all about relationships and connectivity within the body. You have to be able to recognize changes that might be dangerous to your body, and this is what the somatosensory nerve mast cell connection is all about.
Great. We have a couple more questions here. How much do we have time, or do we want to have patients ask? 2 minutes? Okay, great. I'm getting 2 minutes. So we're going to go one each here. All right. Patient has CSU, chronic spontaneous urticaria. Lab work shows only elevated serum tryptase. Patient 1 is greater than 8. Patient 2 is greater than 20. Do you consider SM? No other symptoms of SM. So yes, absolutely. It should be on your differential diagnosis of an elevated tryptase. My practice is pretty straightforward. I check a kit, D816V in peripheral blood, making sure you're using it ultrasensitive, and then I'll send for alpha-tryptosemia testing. Keep in mind, John Lyons has this really cool pie chart, where they looked at, many patients, I think it was like 1,000 or so, and the etiology of elevated tryptase is like 94% alpha-tryptosemia. So both of these patients are most likely to have alpha-tryptosemia, but that does not mean you should not consider systemic mastocytosis. So HAT testing, D816V, via digital droplet PCR, and then you can kind of sort it out afterwards. The only other thing I would mention is alpha-tryptosemia. We're kind of viewing it now as a modulator of allergic symptoms, and so patients with chronic spontaneous urticaria and an elevated tryptase do tend to be a little bit more severe. If either of these turn out to have it, I jumped to omalizumab earlier and more antihistamines earlier in this patient population. Okay.
So we have a question regarding, are there any challenge tests for demonstrating mast cell degranulation? So we have in vitro and in vivo testing. So in vivo testing, anytime you place an allergen on the skin and there's degranulation, that's a local degranulation event. We have individuals that get nasal challenges, and I feel sorry for those poor individuals who are getting medications for ocular and they go into a cat box. So we also have medication challenges for instance, when we're trying to sort out whether somebody's penicillin allergic or antibiotic allergic, we'll do a challenge that way. And then think about vancomycin. If you run it in too fast, that is a degranulation event. As far as in vitro testing, you have the basophil activation tests, and I have a funny feeling as much as mast cells don't get enough attention, basophils are definitely the Rodney Dangerfield, right? So the basophil activation tests are actually a robust way to try to assess in vitro whether or not this person is sensitive to this chemical. You also have physical challenges. Think about all the different things we do for physical urticarias, or trying to understand. I might be a little bit narrow-minded, but when we do challenges for asthma exacerbations, because the mast cells are right along that lining. So there are ways that we give people exposures, and we try to see whether or not they have a dramatic change in function within a certain amount of time. And what I mean by a certain amount of time is minutes to hours afterwards, especially look at alpha-gal. I mean, that's a delayed anaphylactic event for the most part. But I'm happy, again, both of us will be available after this, but we really appreciate you coming early in the morning on a Sunday. And appreciate the questions, and I'm happy to address any questions afterwards. So thank you.
Yep, thank you very much for your time.
Good job. Absolutely.